Now I think we'll segue to sort of our question and answer segment, sort of like our own discussion of the topics that have been discussed. I love the idea of the mobile stroke unit in terms of the application of it. But what I saw on the map was that they seem to be very localized in urban Western cities. And I know that there's an application for more rural and underserved areas, but you see a limitation to that application as we go wider and try to capture those patients who are at risk.
I think the biggest limiting step with the mobile stroke unit has been the cost. And a lot of these MSUs, whether it's the Cleveland Clinic or New York City or Los Angeles, and more recently in Cincinnati, they have come through philanthropy. And I think one goal which Presto has is to mobilize lawmakers that with this you can really save a lot of patients. It adds a lot to the future of stroke care, including the present situation. There's a lot of cost saving, if you look at the long-term costs of this. So just like the stroke system of care evolved after IVTPA became the standard of care, I think this will also continue to evolve because there's a lot of benefit from the MSU level of care. Mm-hmm. And once we have the lawmakers who will be able to fund, so more recently in the pandemic, telemedicine for stroke care also has become reimbursable. Mm-hmm. So I do think as time evolves, this will become reimbursable. There'll be more support economically, and it's a process.
Right.
And to follow up on that, it's interesting. We call these mobile stroke units, but there have been a couple instances where there have been like a crisis or a natural disaster, and they've been able to mobilize them almost as mobile emergency rooms. When you think of the things that they're delivering, the emergency practitioner plus the CT scan, those are some of the key elements. And to your point, I wonder if in areas where there is no CT scan for 200 miles, if a mobile CT would be an answer for some of those underserved areas.
Yeah, I think it's a fascinating area topic, and also thinking about what's the radius of distance that we can serve an area without being too close to an actual medical center. So I think there's a wealth of availability there.
I think every place, depending on the geography, the population and demographics, they would have to evolve their own mathematical models. And the mobile stroke unit in Berlin, they actually looked at their geography and their suburban areas where there was dense population, where it was not. So every place, they would have to evolve their own mobile stroke unit level of care based on their geography, their patient population, demographics, and distances. Just like I think the cardiac chain of care and the trauma system has evolved.
Yeah. No, I think it's fascinating. Jay, I love the whole idea of AI and assessing stroke in the emergency room or even maybe the pre-hospital stage. Sometimes I'm a little bit wary of algorithms because I feel like sometimes we get too stuck in an algorithm and there's not that variability that needs sometimes in the art of medicine. So do you see that as a limitation to it?
I think it was in the first generation of artificial intelligence, machine learning, but I'll give an example, which is chess. I think we're all aware that how AI has influenced and machines have influenced playing like the grandmasters of chess. And what they basically found is in that first generation AI, they were very derivative. They would just they would try every move there was, mm-hmm. and then from those moves, they would be able to determine what the best move was and execute it. That is kind of a brute force approach, and I do think that is a derivative. You're not going to learn new things. But in what became kind of this AlphaGo, different kind of AI was looking at the problem and trying very unique solutions and moves that had never been done, approaches that hadn't been done. And so then they took the grandmasters and they had them work with the machine and collaborate. They would listen to what the machine was saying. They may or may not act on that particular move, but they would learn from it. Mm-hmm. And I think that's the future, is not necessarily pounding algorithms down until they're just every move has been tried, but more the approach of reminding us, I'll give you an example from our particular project. Was we had a video where we asked one of our participants to actually mimic a stroke. She wasn't having a stroke, and we asked her to mimic it. And what we found is her eyebrows were kind of going up more when she was having a stroke, and while she was trying to make her face go down. And that, same way as the kind of the chest massage, you learn from that. You say, okay, well, I never really noticed that when I was evaluating a stroke mimic. Now I'm going to learn from that, and I'm going to use that in my practice.
Yeah, yes, the implication for later on training medical students and residents too, I think that's a strong point. As you know, our limitation when we're in training is always, you know, the type of patients we're coming into contact. So that's another interesting facet there.
Yeah, I do have a question for you, Dr. Mishra. You know, we call it the golden hour. You've ridden on the stroke ambulance. I had one opportunity to do it, and it's also kind of like the blurry hour, the chaotic hour. You know, it's very hard sometimes. The patients collapse. They're in an environment that's maybe a bathroom or their home that is difficult to really figure out what's going on. What, if anything, have we seen about overutilization of TPA or over diagnosis in the mobile stroke unit in that first hour?
I think that's a great question. What the MSUs also involve is the initial paramedic who will be heading to the patient at the site. Those paramedics, and that's how it was done here in Houston, is those paramedics, so the stroke neurologist is actually looking at the patient using the smartphone from that paramedic. So the examination doesn't just begin when the patient is in the MSU, but as the paramedic is walking towards the patient, you can actually see what's going on. So my feeling is seeing the first time what exactly is going on with the patient right on site, that really aids in getting an idea of what's going on, rather than hearsay, which the EMS folks tell us when the patient gets to us. So what I've realized is looking at the patient exactly when the symptoms have started, or just a few minutes later, seeing them, let's say, lying on the floor, not being able to move one side, or exactly looking at those patients just when the symptoms have started, I think that really gives a tremendous idea of what's going on. And then the families at the bedside, there'll be people who really actually saw the patient having the onset of symptoms, or who found the patient. That really aids the clinician in getting a sense of what's going on. There would always be stroke mimics, whether we treat the patient in the ED or through the MSU. But I think this gives you a much bigger sense of what's going on clinically. And sometimes it gives us an idea of if it's a seizure or not. Many a times the history is missed by the EMS because they're not physicians, but when you can see it on the camera, then it gives you a much better idea of what's going on.
And it's a phone, or is it
yes,
a GoPro?
It's a handheld phone.
Okay. And do you find that sometimes I think it's difficult when our telecart isn't working, we rely on the iPad or the phone, the images are a little bit hazy, and it's difficult to see the patients themselves. So I wonder if like a GoPro would be even like something that would be
I think these are all great ideas, but what I've realized is when they design the MSUs, there is also ways of troubleshooting. If one device doesn't work, then you can always use the smartphones from the paramedics.
Great. So where do we go from here? What are some of the directions you think we are heading?
I would say from my angle, it's what we learned. One of the things I didn't have time to include was we learned that the facial recognition was very important, but from our speech recognition, it didn't add as much as we thought it might. We expect slurred speech to be an important differentiator, and what we needed was more normals. And I think you mentioned it's accents. You need people with a large variety of accents. You need people with a large variety of ages. You need all different vocabularies. Mm-hmm. And so one thing that we're doing as our next phase is trying to expand the normal, so the machine knows the normals, mm-hmm. and the variety of normals within our project.
I think as we expand the MSU level of care, this is just the beginning. Yeah. And by the time this thing expands, and hopefully it does, I'm very sure it will. With the available treatments that we already have, we can make a huge impact to patients' lives by golden hour treatments. And that itself can really turn the chapter on stroke.
Yeah, no, I definitely agree. Well, I thank everyone for their presentation, and I hope that everyone online and viewing has enjoyed this first part as much as I have. We're going to cut to our break and bring on our next panel of presenters.